Hi ครับ Richard Good morning
ยังไม่เข้ามาเลย
เข้ามาแล้วค่ะอาจารย์
ไม่เห็นนะดิเจนนี่
Good morning Dr. Richard Hi Justin
Hi, everyone.
Hello Justin how are you
Good to see you. Mr. Surapon. Hi, everyone. Hi, Richard.
yeah how are you Richard
I think you're on mute, Richard.
Hi Dr. Richard Sorry
Muted. I was going to say hello, everybody. It's almost spring, and everything always looks better in the springtime.
Hello Richard how are you Good?
Pretty good.
Mm.
Yeah, we're busy. Oh my,
busy as always
it seems busier than always. It's crazy.
Too bad, huh?
Yeah, your colleague Smith just we have our first of our series of papers that we're working in that just got accepted.
Oh, how very pleased to hear that. In which journal?
Well, this was a review where we were asked to work on. We have a couple of things. So we have some retrospective studies. We have a prospective study, and we've also got a couple of reviews. So this was
Good.
a review on. He did a very good job. Where are we
Good.
today, and how did we get here on the development of cytokine growth factors? We have another
Okay.
one on cell therapy and one on tisagenlecleucel.
Very good. Thank you very much for helping him.
Well, we hope it's helping him. I mean, he's definitely a good scholar, and when he comes back to Bangkok, he's going to be, he's ready to go home, but two, he's
Yeah.
definitely he's been exposed to our program, so he's learned that he's seen a lot now.
That is very important for him.
So, so from last time, I basically was given a review of ASH and ASBMT.
Yes.
And that was only a few weeks ago, but it turns out that because 2 weeks from now I'll be in Europe for the EBMT meetings.
Yes.
I put together a talk, but I didn't finish it. So, and then Jenny shared with me that part of this also was to try and concentrate on some heme malignancies. Now I have going to have some of my own colleagues give independent presentations, but on this one I sort of decided because it's focused on heme I will continue my ASH and ASTCT review, but also provide some insights and updates on that's relevant to all heme malignancies, and specifically we'd start with AML. Some new approaches, and it's by one of my colleagues here who I hope in the next year I can have speak, do one of these full dedicated hour presentations. But I think because he's a good teacher, but I think he's published a few papers recently that are very getting a high profile. So I thought I would show some of his data. So
today
before
you will present for the whole 60 minutes.
Yeah.
Okay.
Yeah. No, I haven't.
Actually, we prepare a case presentation, but maybe next month.
Oh, what did you? I heard. So what did you prepare?
A case presentation and discussion.
Oh,
maybe
well,
next time.
Okay, we could do next time, or we could just make sure I just end faster.
Okay, maybe we send you the detail of the patient, and then we'll discuss next time.
Okay. Then I think the next time was scheduled to be a BDMS presentation on the schedule that Jenny sent me.
Mhm.
Well,
So,
either way,
Okay.
so are there questions or anything for me before we start?
I think today would be the regular presentation, and then maybe next week or so, that will be the BDMS presentation. Is
Oh,
that okay? That,
yeah,
not next week, the fourth week of March.
of April. Let me find out. So for one thing first.
Okay.
Um,
Let's discuss in by email then. Nah?
yeah, no, we could do. Yeah, so it was. I could show you quickly just what I heard from Jenny,
Yeah.
and it's right here. Do you see that? Nope, not that one. Stop that. Because don't worry, it's this one. Yeah, so this one. So this would be the BMT lecture. Then I would in March. Today would be a hematology lecture, and then in April there was presentations from BDMS. Then we can move this around, and yeah, if I'll send this to you by you know by email, and because this is what I was working off of. Okay.
Okay. Okay. Oh,
What I'll do is I'll send it. You and I'll email this. I'll email you this directly. We'll work on it together.
okay. Good.
All right.
Yeah.
Now, do you see my slides now?
Yeah.
Are the slides showing?
Yes.
Okay, good. I just had one on top of the other. So again, this is what we talked about last time. This is updates from ASH and ASTCT, and I call this part 2 because I didn't really get through it all, and so I think I sent the whole presentation, but I've built on it, and I've added a whole bunch now in AML because it is supposed to be some hematologic malignancies also. So we'll see where it takes me. I have a feeling I won't get through this either again, but I put a story together and see where the story takes me. So first is to talk about AML, because there was a lot at ASH about the changing world of AML. I mean, for us that we've been doing it for 40 years and very little has changed, well, all of a sudden AML is is a completely different disease now that's attracting a lot of people to go back into the study of AML. It's still important to be able to prognosticate the outcome of a patient, and models are being increasingly individualized. In the older patient, which we always said is chemotherapy, hard to deliver chemotherapy to the older patient, but now we know that hypomethylating agents and venetoclax is now often the first step. So that alone has changed the natural history of managing of AML. It changed the natural history. It means people can get into remission that wouldn't have otherwise, and they would have lived longer. However, most patients still relapse and die of AML. So this hasn't necessarily changed the paradigm that makes it a curable illness. Transplant makes it a curable illness, but it changes our ability to manage a patient and give them more, family time and time to finish what they need to do. And this is what a lot of ASH was. They're now showing that you can add a third agent to hypomethylating agents of venetoclax that look promising. Now, when we look at AML, it's a reminder that the vast majority of people are older age. This is over 50% of patients are over 60% of patients are over age 65, and the median age of diagnosis in this upper age group is 69. But when we look at this age group, then 60 to 75, we still struggle with the over 75 and the over 80-year-old of how to manage. But in the 60 to 75, we consider transplant now to be a standard approach for patients up to age 75. But if we don't go to with chemotherapy alone and not going to transplant, you could see that this is our overall survival is still at about less than a year if you're not transplanting. And even now in 2012 and 2016, we have about a 20% at best 5-year survival. And so everyone knows we have to get better. Well, the guidelines, the European Leukemia Network guidelines were updated last year. This was published in Blood, and it points out now, as opposed to favorable being cytogenetic only, the mutations are now becoming part of the guidelines for stratification for individuals. And this is for patients who are going to be eligible for hypomethylating agent venetoclax, so lower intensity regimens. And so there's a group of mutations here, and then intermediate is other cytogenetic or abnormalities, and adverse still remains mutated. So the big question is, are all these equal? Well, it turns out, I was saying, one of my colleagues at OHSU has used the BEAT AML database that has over 1,000 patients now, and that was something that Brian Drucker could put his effort into, is to building and changing the AML. What we now know is that these 4 mutations, so if you have a favorable risk group, it turns out that if you go to the ELN favorable risk, going back to this slide, this whole area, that the favorable outcomes are based on these mutations. If it turns out that you called ELN favorable, but you lack these mutations, like they're wild type, you'll find that survival is significantly impaired. So we can start to subdivide the categories. And so Dr. Lakowitz wrote a paper about this and published this in Blood also last year, which is this is the ELN stratification. Mutated P53, if it's yes, you're adverse risk, or no, then you look for NRAS or KRAS for FLT3. That will define intermediate risk, and then no, then you have these other ones to classify as favorable. Now you could propose that if you have mutated P53, KRAS, and now I'm not showing all the data, but PTPN11, those are positive. They are all adverse risk. It turns out the PTPN11, it was a bit of a surprise, but it came out of the BEAT AML database. Those patients do poorly, and they should be considered adverse risk. And then you see the others still stay as mutated risk and favorable risk. And so we're starting to see some evolution of the models. And to the point that he was invited to give a ASH educational talk, and they've come together for elderly patients. Here's a new stratification or a new approach to how you might treat them. They're all going to be azacitidine and venetoclax based treated, but you can see here's the mutation frequency. But you could start to pick, like for IDH1, you could think about adding IVO to see if that will enhance outcome. If it's IDH2, you can add inatisib. For FLT3, we have a host of the FLT3 inhibitors. This is important, is the new KMT2A, which I'll show in a minute, the mutated. This is this was a big discussion at ASH, there's now 3 FDA approved menin inhibitors. So the classic 11q23 abnormality, which is associated with secondary leukemia, well, that turns out to be disrupts the menin methyltransferase gene, and that can now be overcome with an inhibitor. Similarly, you can go down and you can now apply this and start to more personalize the leukemia management of the elderly patient. And so again, this is his view that he shared with us. And if he speaks at this conference, you'll hear him, go through this in detail. If you start with the patients who are ineligible for chemotherapy, you got these azacitidine venetoclax, and you could use them in a hierarchy based on the mutation that can guide your therapy. And I just remind that the KMT is the it's the menin lysine methyltransferase enzyme 2A. That is the source of the menin. That's the new target for menin inhibitors. And this strategy can be used for chemo non-intensive. If you have a patient who's younger and you feel you want to offer chemotherapy, we also can use those mutations to guide our therapies. So certainly FLT3, we have the RATIFY trial from a long time ago demonstrating that midostaurin, which is a FLT3 IgD inhibitor, we have better outcomes with that. We know with the CBF mutated disease like inversion 16 or 821, that turns out that studies from Europe as well as the United States show that adding gemtuzumab makes a difference. So very low dose, not the original 9 per meter squared times 2, but a low dose gemtuzumab added into induction can improve outcomes. And so on down the line based on the mutation. And, revumenib is a menin inhibitor, so you want to think about menin inhibitors. That's what I believe that was the first FDA approved menin inhibitor. But you can use this into how you approach patients. And if you get to remission, whether you feel they can't go through chemotherapy or you still could think about allogeneic transplant, whether it's a reduced intensity or non-myeloablative or fully ablative, and you still can potentially use about maintenance. So there's a lot of progress, but this is a reminder though that this is from a real world database that came in the United States, newly diagnosed AML, 5,000 patients newly diagnosed, 900 with refractory anemia, refractory leukemia. What you could see is in this dark blue are the percent, this is over half a decade. This is a slight reduction, but this is the number of patients who are not receiving any induction therapy. People are deciding pretty much right from diagnosis that they're not salvageable and they're not being treated. So this is the no treatment. Then we have chemotherapy treatment, and then we have HMA-based therapy and so on. But there's still a lot of patients that don't get to treatment. And so it's something we need to pay attention to. One of those things that came up is, what about referral patterns? And there's 2 studies looking at these are patient outcome related, studies. Who gets referred? And this was a paper from came out of Moffitt with other collaborators from the Fred Hutch and Sarah Cannon. If you don't have insurance in the United States, will you get referred for transplant or not? This is the hazard ratio. And you can see that, the vast majority of people, you're 700-fold not likely to get referred for transplant than someone who has coverage. African American versus Caucasian, you're also seems to be a barrier to referring for transplant. Female or male, no difference. But importantly, a young patient almost always will get referred. In 60, not 70 or 80, but even over 60 years and over, still has a high hazard ratio, a high percent. That I think for those of you on the call, don't look at these numbers. This means if you're 60 years old and over, you're 729% more likely not to be referred for transplant than someone who's 30 years old. Another study looked at, these issues associated with, not referring for transplant. Separate study, separate publication. Vijay Bhatts at University of Nebraska, who's interested in the leukemic care of the elderly. Turns out, if you're older age, or if you're in a small private hospital or a small, nonprofit hospital across the country, and you don't have ready access to referral to a non-academic hospital, a lot of the patients, the decision is made for them by the referring hematologist to say, probably shouldn't go on to, it's too much for you. It's a hardship. don't refer for transplant. And then we have these other things that sort of match what we saw in the previous one. Now, something we're paying attention to is this was a study that came out of a Southwest Oncology group. John Pagel worked with Fred Applebaum on this, which is, can we actually HLA type somebody fast? And so this was a companion study to the Southwest Oncology group AML study, with the goal is what % of patients could be have HLA typing completed and reviewed by day 30 of induction therapy. And they looked at it compared to the past. And what they could show is that if you can identify a donor more quickly, you're more likely to get to a transplant. And so, well, that's sort of the summary here. So the cumulative incidence, this is for high risk patients, this is for low risk patients, lower risk, but you're more likely to get the transplant. But if you could see, if it takes up to 6 months before you start to find something, your likelihood of getting a transplant, goes down. Over here is showing this, what is the impact of that proactive donor identification? If someone goes to transplant within 6 months, because in CR1 versus not go to transplant, long-term, better outcome for earlier transplant, which means earlier identification of a donor translates to earlier, transplantation, which leads to earlier outcome. So this was a landmark analysis for overall survival. This is relapse-free survival, also showing the same. And this was high risk, showing that high risk still also can be impacted, although there it wasn't statistically significant. So we think, well, I was going to say, we think this is important. We've actually started a study at OHSU, which is when from the day we start induction therapy, our goal is now to use mutation analysis complete, identify a donor complete, and if we're in remission, what we're studying is how many patients can we start conditioning for the transplant by day 60? That is the goal of our proposed study. It uses a more intensive induction regimen. The FDA has given an IND for it. We'll be launching that, and we hope that we are going to impact people. A study that this is an old study, for you to know, 7 and 3 has been our standard therapy, 7 days of cytarabine, 3 days of an anthracycline, whether it's daunorubicin or idarubicin. Those have been standard forever. A compound was developed, well, the trade name is Vyxeos. It's CPX351. It's the same drugs. It's 7 and 3, except it's actually given in a liposomal carrier, and so it has more delayed delivery. And it turns out it may be less toxic. Interestingly, same drug dosing, people don't lose their hair with CPX. It does get deeper cytopenias, and as opposed to with 7 and 3, when you might see normal hematopoiesis recover by day 24, typically you won't see normal recovery until day 35 with CPX. But these are data that led to its FDA approval. And this is from time of randomization of CPX. You can see CPX had a survival benefit, and that survival benefit, patients were referred to transplant, it even carried through to transplant. So CPX is still indication for, this is in high risk leukemia. Typically is where it's done, and where CPX has got its FDA label is in secondary AML. So one of the reasons, why are they doing better? Well, it turns out that relapse is really not that much difference. But the survival advantage associated with CPX is basically non-relapse mortality. They're decreasing the risk, whether it's an infectious infectious death or an organ death. CPX is associated with, basically a lower risk of NRM, and that translates to the survival. And what came up just recently is European real world evidence. Europe has really adopted the use of CPX for secondary AMLs or transformed AMLs from underlying hematologic disorders. And they also can confer that there was an improvement of overall survival, excellent overall survival, but importantly, deeper remissions. They were able to get into, a deeper remission. And if you could get to an MRD negativity, that actually translates to better outcome. So going on with AML, so this was originally going back to the original trial that said venetoclax could be good for you. So we're saying CPX could be a good drug, and it's a good drug for secondary AML. And it's actually because of its lower risk mortality, the non-relapse mortality. When someone would be a little bit afraid to give 3 and 7 to a 70-year-old, or even up to a 75-year-old, I could say that I have used CPX to patients up to age 75 without significant toxicity. So that is an option. So we know that in the past, we used to do azacitidine as a standard of care. There was an old data to say azacitidine versus best supportive care had a survival advantage of AML. Well, this is the study there was a study that was first came out to show what happens if you add venetoclax to azacitidine. And this was a randomized trial that for patients showing that venetoclax plus azacitidine had a very improved statistically significant survival rate, doubled the survival rate, approached over 3 years. Again, felt to be now a new standard of care, and we all are using it. So this is showing back that real world evidence supports CPX 351 and also supports venetoclax and azacitidine. Transplant does provide improvement of overall survival, ultimately. With these agents, if you follow over time and you don't go to transplant, you still ultimately, you may have improved outcomes over not doing these drugs, but you still ultimately, by 3 years, have a good chance of dying of disease. But here, the transplant improves that outcome. So we still support transplant. So what about maintenance? I'm going to try and I'm going to already tell I'm talking too much. What about FLT3 maintenance? So this is something that's dear to my heart. I've done studies on this and ran a national study on this. And so we now know that FLT3 inhibitors are part of the induction therapy for AML and also to administer during the remission, the consolidation cycles. Is there a role for maintenance therapy? Well, there was a study of oral azacitidine. I'll talk about that in a minute. But in the post-allogeneic study, in the post-allogeneic transplant, there have been several studies now that have looked at maintenance therapy with sorafenib. The SURMAIN study came out of Germany. It ultimately closed early because of poor accrual, but there was a statistically significant benefit for patients who got sorafenib. It has category 1, treatment. So midostaurin, I was the lead investigator of the midostaurin study used in remission. It turned out that in this case, we actually did hit accrual targets, but it was underpowered. And surprisingly, the placebo group did tremendous compared to all past history. But when you actually looked and did an analysis, patients who you could demonstrate that the FLT3 ITD had phosphorylation reduced, inhibited by 70% or more, then you could still show there's a statistically significant benefit of midostaurin. So it was given category 2B. And we'll talk about gilteritinib and quizartinib, which are more specific. These are considered dirty TKIs. They inhibit many, many tyrosine kinases and serine kinases. These are more specific. And so some people think these would be cleaner. And we'll talk about them, but both of those have not had overwhelmingly compelling data to say they absolutely should be given as maintenance after AML in transplant for FLT3 ITD. So we were part of the BMT CTN study. I was actually on this came on an original proposal, one of the proposals that we had submitted to the BMT CTN. It led to the Morpho study. This was an international study sponsored by, it was run by the BMT CTN, but sponsored by the industry sponsor. Patients had to have had FLT3 ITD AML. They had to have gained a first remission, morphologic first remission, within 1 or 2 inductions. They then would have a marrow aspirate for MRD analysis using a very, very deep and sensitive PCR. It's not the standard commercial FLT3 assay that's out there. They would then be transplanted within the first year, and between day 30 and 90, they would start gilteritinib. And samples get taken, and then what they would do was gilteritinib versus placebo. And what they were doing to see is with randomization was, it was 2 years of maintenance, was there going to be a benefit? I could tell you everybody thought that this was going to be a slam dunk for the TKIs, partly based on the SARMAIN data. But, you know, what did we find? And this was presented, you know, at EHA last year, and it was updated at the recent ASH. What you could see is there was really no statistically significant benefit in overall survival or relapse-free survival when you use gilteritinib as a standard approach for maintenance in patients. And this was presented, it was, so in some ways you'd say this is a negative trial. Well, it turned out, it actually turned out to be very informative, because the scientific correlates that were done there was using this very next-gen sequencing assay. It was very deep sequencing, the ability to detect the FLT3 mutation to a sensitivity of 1 in a million. So again, this is more quantitative than what is typically available when you order it commercially. And so what they did is they would identify MRD positive status. And what they showed was if patients were either MRD positive coming to transplant, or importantly, MRD positive on day 30 after transplant, those patients benefit with gilteritinib. If you were MRD negative using that assay, either coming to transplant or on the day 30 assessment, you could see in that setting, those patients have ultra-sensitive disease, the cure rate is extremely high, and you don't need the gilteritinib. And so it did teach us something. And so we can now stratify and state that, you know, MRD is going to like impact, you know, the outcomes. What they now have also done further work to show that if you have more than one mutation, you know, besides the FLT3 ITD, you're more likely to be in this a lower relapse-free survival than if you had single. But gilteritinib absolutely, you could see positively impacted the outcomes for the MRD detectable patients. So what are our take home for FLT3 AML? Well, MRD positive patients benefit from gilteritinib. Patients should only be considered MRD negative, but if and only if you do the right assay, and that assay I believe now is becoming commercially available. If you're not transplanted, you know, most people would use maintenance therapy because the quizartinib and crizotinib studies have shown a benefit. I think I'll skip this stuff, these next 4 slides. I'm going to go right here, because this is where I left off on the last session. And so I can get the next 15 minutes about, you know, what I didn't finish from last time. So people, like we talked about previously, that CAR T for lymphoma, CAR T for myeloma has been very exciting, has changed the natural history, is even curing patients with lymphoma that we wouldn't have dreamed could be cured. Well, people have been trying to develop CAR T for AML, and they've mostly been small studies, been published, and you can see small numbers, relatively high rate of, you know, of of CRS and ICANS. There were some very decent degree of patients who would get to a disease response and even remission, but in effect, it was only done to bridge patients to transplant. CAR T by itself was not going to be satisfactory as a primary therapy. And there's a whole host of things that are happening. So can we improve on this? Because the data so far has not been exciting. And like I said, most people they'll have a CD123 CAR T to purge the marrow and then go to allotransplant. And so there you have a $500,000 procedure followed by a $500,000 procedure. You're spending a lot of money in it. And how much is that better than just going to AML directly to transplant? But either way, people are trying to improve on it. Well, this was published last September, 6 months ago, based on a prior ASH, which I think is really interesting. And I may have mentioned it before, but so this is a Sar Gill's group published this, and I will tell that whatever I think I keep saying that whatever I read from Sar Gill in his laboratory, it's always just smart. And what they did is they tried to develop a CD123 directed CAR, study. They found 20 patients that they started to, manufacture CARs. Only 12 were infused. 8 of them died because of refractory leukemia before they had a chance. But they looked at the 12 patients they infused. Well, it turned out there was 4 remissions, 3 partial or progressive disease, 5 stable, 2 died of non-relapse mortality due to CRS, and only 2 were alive long term. But in all those patients, almost all those patients, they had cytokine release syndrome. And so he was raised the question, does CRS have any impact on that low response? Normally, we think that CRS should be good because it will activate the T cells. But he thought, well, maybe it's doing something different in AML. And so they went to the laboratory, and what they showed is they collected cytokines, they collected samples of those patients. And what they showed is that JAK-STAT signaling pathway was upregulated in the leukemic samples. And so why is that? Well, it turned out that basically, I'll summarize, when the CAR T comes in and it starts to see its target, it starts to try and kill the target. You get cytokine release. The cytokine release are all, we know about IL-6 and maybe IL-10, IL-12, IL-17, but it turns out that GM-CSF is also coming from the macrophage monocyte population. And when the GM-CSF comes in board, it turns out that AML cells have a receptor, a growth factor receptor that will respond to exogenous GM-CSF. So in a way, you're getting paracrine stimulation of the AML. So while your CAR T's trying to kill, the cytokine that are delivering is protecting the AML blasts. And so with ongoing exposure, the T cell keeps trying to kill, the AML keeps resurrecting itself, and finally your T cells exhaust, and then the AML overgrows and you die. What they said is, well, if we know GM-CSF is a surface receptor, and we know it runs through the JAK-STAT pathway, they asked the question, like, here's in the laboratory, here's GM-CSF stimulated blasts, and here's it with ruxolitinib. And ruxolitinib seems to eliminate the resistance of the AML blast to the CAR T. So what they propose, and they are supposedly writing a clinical trial, that they're going to develop CAR T for AML with ruxolitinib, because the ruxolitinib should theoretically block the paracrine stimulation via the GM-CSF receptor of the blasts that are given, potentially contributing to resistance. Very interesting pathway, very interesting biologic study that in this case was a classic you had a trial that CAR T was this is bed. They identify this activity, went back to the lab, so bed to bench, and now going back to bed. I think this is also interesting, by the way, which is something new to pay attention to. This is a visual extract. This came out of blood. This to me is really, really interesting. This company has developed an AML cell. So there's an antibody that sees WT1 and HLA restriction. They've now made a CAR that's where they take the Fab portion of the antibody that would bind to the peptide in HLA, and they hooked it up to the gamma delta T cell receptor. Now we always worry about alpha beta receptors staying on board because they could go ahead and do adoptively transfer, cause GVHD or whatever. Here they put it to the gamma delta receptor. In general, gamma delta T cells are relatively inert, but then they did put a second CAR that sees the classic CD33, and so that will have a stimulatory. So it's a dual receptor CAR where they can use the CAR to activate the T cell receptor, but the T cell receptor is a normal T cell receptor that creates the immunologic synapse that's intact, and then you have normal T cell signaling. Their preliminary data with this sort of approach was done first in lymphoma. There is almost no CRS or ICANS. And so what they hope is that they're going to be able to develop this technology into autologous lymphocytes for patients and be able to, potentially treat AML. All right, I got 20 minutes left before I go on. Any questions?
I would ask Dr. Surapon to correspond with you on this อาจารย์เชิญเลยค่ะ
Okay, in the absence of a comment, I'll just go on.
Thank you very much, Richard.
Okay, well, this is about AML, myeloma. We know that there's myeloma CARs. They classically are seeing the target antigen BCMA, and that BCMA is a target also for immune conjugates as well as bispecific antibodies. We now know that CAR T has been approved for advanced myeloma, and so this is idacaptogene and ciltacabtagene. This is for fourth-line therapies. They were fifth-line therapies. These were two publications in New England Journal last year, which would show that idacaptogene and ciltacabtagene had improvement over the best next line therapy. So now we have FDA approval for offering CAR T either in third line with idacaptogene and actually in ciltacabtagene, cilta-cel, that can be offered in second line. It can be offered to patients. The way they did their study is that patients had to be lenalidomide refractory. So many of these patients had 3-drug induction, got a transplant, were on Revlimid maintenance, and then they went on to CAR T. 50% of these patients never saw a CD38 antibody. Almost in this case with idacaptogene in second and third line, almost every single patient had been previously treated and failed CD38 antibody. So I'm just pointing that out because you can't look at these two figures and say this one is better than this one. This had a much better patient population up front. The important thing I want to point out comes out from CARTITUDE 2. This is a cautionary note that if you are developing, if you're going to use ciltacabtagene or idacaptogene or if you make your own CAR against BCMA, what they noted is, again, if we look at the response of cilta-cel in someone who had never had a prior BCMA exposure, it's a 90% response rate. However, if you had patients who either had prior bispecific antibodies or prior immune conjugates against BCMA, the overall response rate drops from 90 to 60%. The duration of response drops from actually over 2 years down to 11 months. And the MRD negativity rate goes down, is a much lower percentage. So it's just important to know that we have to be aware of that when we do something, that when people say, oh, I can do this first, I can do a BCMA and bispecific antibody, and you could do your CAR T later. That in myeloma, that may not be the best idea. Now, there was a real world assessment done a year ago, looking at ide-cel versus cilta-cel. This was very small numbers at the time. It was only 18 patients with cilta-cel, 35 with ide-cel, but the progression-free survival with very short follow-up looked different. Well, this has now been updated this past ASH, looking at the safety and efficacy. 19 institutions put their data together for the U.S. Myeloma Consortium. They did a propensity score matching. You know, that issue about how do you compare group to group? A propensity scoring allows you to sort of at least pick similar risk coming forth. And so what they identified was 586 patients who were infused, 350 had ide-cel, 236 had cilta-cel. For safety, on a safety measure, cilta-cel was a harder drug. Higher rates of CRS, higher rates of infection. On the original approval study for second line and third line, 9% non-relapse mortality at 1 year with cilta-cel. Also, a high percent of delayed neurotoxicity. This agent has Parkinson's-like activity, has been associated with Guillain-Barré and cranial nerve palsies, much higher. However, when you look at efficacy, the efficacy clearly was suggesting for progression-free survival that this again is a retrospective real world, that in a propensity match group, that cilta-cel was still going to be superior to ide-cel for control of disease. With this early juncture at follow-up, overall survival was equivalent. It's just the at that point. So the hazard ratio the same. Oh, and this is like showing that the non-relapse mortality is impacted though, with response being better for CR or better, higher with cilta-cel than with ide-cel. Overall response rate was equivalent, but CR better. Delayed neurotoxicity, higher with cilta-cel, infections higher with cilta-cel, and high-grade CRS, really hazard ratio is 6.8 versus 1. So 580% more likely to have advanced CRS with cilta-cel. So when you use cilta-cel, be careful. It's got potentially better long-term, but you will have toxicity. Maybe at a future time, I'll be able to share autopsies on 3 patients that we've treated over the last year and a half with cilta-cel, who basically developed advanced ICANS and died of ICANS, and where we learn a lot along the way. Now, just to say though, that is all about BCMA CARs. Well, there's data coming out that there's another target molecule on myeloma cells, the GPCR5D, and that also is now being used. And these are patients who've had multiple prior regimens. They've all had 38, they all had auto transplant, and many patients have had prior CARs. So 50% of the patients had prior BCMA. And again, now you're looking at a different antigen. When I showed you before that BCMA exposure before BCMA CAR, caused an issue, now we're looking at a different molecule, GPCR5D, to rescue BCMA failures. And what they find is 82% had CRS, but most was low grade. ICANS was very low at 10%. But overall response rate was almost 90%, with a median follow-up of about almost a year and a quarter, but median progression-free survival, 14.5 months. I think this is significant because when you look at the data of second auto transplants, when you decide to do a rescue auto transplant, it's typically about 18 months. And so, now this is rescuing CAR failures. So we're still getting a year and a quarter out of it. Impressive data. This is a new type of car that we're going to watch for. This comes out of China. We're looking at BCMA and CD19 dual targeting, including a lot of patients with extramedullary disease. 3 dose levels, small number of patients, but this is the first showing you the pilot. Also short follow-up, but median 5 lines of therapy, 65% high risk cytogenetic, 65% pentarefractory, overall response rate 100%, 90% CR. Even in the extramedullary disease, which we know in cilta-cel and ide-cel are difficult to treat, 86% response rate, 64% remission. At 1 year, interestingly, they could detect circulating CAR T still in the bloodstream at 1 year. So I believe this particular product has now been licensed by a U.S. company, and we will be opening this dual CAR coming up. I want to skip the next couple slides, which is about, I think I've shown some of this before. This is a study that we were very active in. I'm on the paper, I'm on the studies, but it's very interesting because instead of a classic CAR T or they basically isolated the binding domain of the anti-BCMA activity. So it's a much smaller molecule, which means instead of getting a transduction efficiency of 20, 30, 40%, they're guaranteed almost transduction facility of transfection efficiency of 70 or 80%. Also, it's stable. There's less tonic signaling. And what they also believe that it's going to give good killing with lower toxicity. Well, the sum total is from the phase 1 data, which was presented a year ago. And now we have the updated, iMMagine-3 is the phase 2 registrational trial. The primary endpoint, 62% of patients with a complete remission, 20% extra, so 80% were in very good partial response, almost 100% overall response rate. And when you look at overall, survival at 6 months and 12 months, almost 100%. The important thing is, I think I have it here. Maybe I don't. Maybe I don't. I'll go back here. I know I have it. If you look at CRS, there was no cases of CRS with this agent, no greater of grade 3. There was only 1 case of advanced ICANS out of 25 patients. That same, really good risk disease, good risk outcome was seen with the phase 2 registrational. With the next 5 minutes, what's very new? This was one of the plenary subjects. I won't go into detail, but this was a plenary one of the chosen plenary abstracts at ASH. They were asking, does diet actually influence outcome? So this is all mice, but they say there's 5 representative diets that people have said is a good way to live. Ketogenic diet, high fiber, high fat, high protein, or the Western diet, which someone like myself who stops at McDonald's or at supper or stops for pastry for breakfast, I'm probably in that diet. Well, they've looked at this. It turns out, interestingly, the ketogenic diet, when looking at CAR T for a mouse model of CAR T, the ketogenic diet was associated with improved overall survival. And what they've analyzed is the biologic basis is that beta hydroxybutyrate was significantly higher. They can track it, using carbon-13 labeling, and they can actually show that the concentration in the serum will actually influence the CAR T function. So they are now going into and they boost T cell proliferation. So they are now planning a beta hydroxybutyrate diet supplementation for patients going to CAR T. Interesting. The other one I think that you'll enjoy that was presented at ASH is a first-in-class CAR T for myeloproliferative disorders. And so we know there's always, when we think of myeloproliferative disorders and we think of myelofibrosis or P-Vera or ET, we think of JAK mutations. Well, we know there's a 15-20% of myelofibrosis and myeloproliferative disorders have mutations of calreticulin. And the mutant calreticulin drives the MPN. Well, they now know that the mutated calreticulin will bind to the TPO receptor, and that helps activate the cell, and it will actually display a cancer neoantigen. So this group has made a CAR T against the mutated calreticulin, and then they tested it from 12 patients, not on patients, but they made organoids in the laboratory as well as getting isolated CD34 cells. And what they could show is a high depletion rate with their a high depletion rate of the calreticulin or the myeloproliferative samples. When they used a control group of JAK2 mutated samples, there was no killing. So it does seem to be specific for calreticulin. And if you pre-treat with eltrombopag, which increases surface TPO receptor by 50%, not romoplastin, you actually improve the killing. So we think people are questioning or already reaching out to talk about opening CAR T studies for myeloproliferative disorders. I'll skip that one. What's coming next? I think we all know about autoimmune disease. I have 4 minutes. I'm going to just say lupus we have data from 2022 from the German group that all the biomarkers within 90 days normalized. They updated their data at ASH last year, showing excellent outcomes, not just with lupus, but scleroderma and also inflammatory myositis. Again, excellent outcomes. 8 patients with lupus, complete remission. Myositis, response at 3 months. Scleroderma, all improved. Importantly, for one of the diseases that we see, autoimmune hemolytic anemia, another group, this is another study from China, patients with refractory autoimmune hemolytic anemia failing more than 3 therapies, failed everything, took them to CAR T therapy against CD19 with a median follow-up of 8 months, no minimal ICANS, minimal CRS, 100% complete remission. Only one of those 8 patients relapsed. And so what we think is that CAR T for autoimmune disease that rheumatologists and neurologists manage, but also autoimmune diseases that we manage as hematologists may be something that is coming. So work continues, work evolves in the morning, all at night. We're always working. We're on 2 sides of the Pacific, and that's it for now. So let me stop sharing. Saves a couple of minutes. So I tried to upgrade my second half of the ASH ASTCT update, focused on heme malignancies, keeping up with Jenny's request. I always do whatever, when someone asks me something, I do my best to listen. And I always know, listen to the woman, because she's always right. And so Jenny, thank you. And I hope that was useful. And when you share it around and take the time to look at the slides in detail, that it's instructive for you.
Thank you very much, Richard. It's just like that I have attended the ASH. Very, very, very informative. I have one question. In those old age AML who with the high risk, who respond to the induction with Vidasa and venetoclax.
Yeah.
What is the good maintenance treatment after remission? So
what we've done for a number of patients is continue the venetoclax for 2 or 3 cycles, and then but by the first cycle, what we're doing studies now on lowering the venetoclax exposure. So instead of for 4 weeks down to 2 weeks, azacitidine for 1 week, venetoclax for 2 weeks, do a second cycle. And from long-term maintenance, people, once you get to a remission, we've been holding the venetoclax and just using I've been just using azacitidine.
Mm-hmm. How often and what is the dose?
Well, azacitidine once a month, 7 days, if we can do it. Some people do, some centers that don't have infusion 5-7 days a week will do it 5 days and 2 days. Some people just do 5 days, but I don't stop. So it continues. And I actually have patients who with high grade myelodysplasia who were actually before venetoclax that we treated who went into remission with azacitidine. I have 2 people beyond 7 years that I still have on azacitidine. We've had other patients who've stopped azacitidine, when they were supposedly controlled, and almost all of them within 8 to 12 weeks, the leukemia comes back or the high grade MDS comes back. So I do not stop the hypomethylating agents. So if someone gets started and gets a good response, they're on, and they're not going to transplant, they're on them for life.
We use the low dose of venetoclax
Yep.
for short duration, 5 days,
Uh-huh.
every 6 to 8 weeks, and it works well.
For continually for 1 to 2 years, or do you stop
Yeah,
venetoclax?
Yeah, up to 2 years.
Okay. Well, I think, like I said, there's a lot of things being developed, and I think because I only transplant people, honestly, I just do the transplant. Those patients who don't come to me, I think I still have managed them with AZA, but maybe whenever we get Curtis on, he'll have input for you about, how he's using maintenance venetoclax.
Okay. Thank you very much. It's very informative. Thank you.
Well, I just
Have a nice weekend.
yeah. Well, you guys have a good work day and today, and I will email off in the next few weeks. We'll email ahead of time about
Okay.
planning, and Jenny, I will involve you with that too.
Okay. Thank you. Bye.
Thank you, Prof. Please send us the slide as well, so we can share with
Yes.
the.
Yeah, I will. Like I said, the slides from last month had some of these slides, but I've increased them, so I will send you today's collection.
Thank you very much.
Thank you. Yeah.
Okay, everybody. Hope you all have a good
Okay.
month.
Bye. Thank you.
To
Bye-bye,
you via
Justin.
email later, Dr. Richards.
Okay, I look forward to
Okay.
talking to you all in person again sometime soon, maybe.
Okay.
All right.
Thanks all. Thanks.
Enjoy your day.
Until then, bye-bye.
Bye.